Let's talk about one of the most dangerous situations you can face in healthcare, the combative patient. These moments are incredibly high stakes, they're unpredictable, and they demand a cool head that's backed by a really solid plan. So we're going to break down the clinical guidelines for managing these encounters safely and effectively.
I want you to picture this. A situation is escalating fast, and your patient becomes aggressive. They're a danger to you, to your team, and honestly, to themselves. What is your absolute first move? Think about it, because your answer to that question, it dictates everything that follows.
So before we can even jump into what to do, we have to understand the problem itself. A combative patient isn't just someone who's angry. What we're actually looking at is a complex medical and safety crisis, where just one wrong move can have, well, disastrous consequences.
This is so much more than just behavior. We could be dealing with something like a traumatic brain injury, a TBI, that completely strips away the patient's ability to make rational decisions. And at the same time, here's the kicker. The very tool we might use to help, sedation, carries its own massive risk of dangerously low blood pressure. Every single element here is a potential minefield.
Okay, so with all that complexity staring you in the face, where do you even begin? The guideline is crystal clear on this. There is one principle that overrides everything else, and it is absolutely non-negotiable.
Let's be perfectly clear about this. Before you can even think about helping the patient, you have to ensure your own safety and the safety of your team. And look, that isn't being selfish. It's essential. An injured provider can't help anyone. This is the foundation that every other decision is built on. So, the practical steps follow a really clear hierarchy. You first, then your team, and then the patient. You try to protect the patient, sure, but never by putting yourself in harm's way. And notice how things like calling for law enforcement and using restraints are framed here. They are deliberate, serious actions, and you only pull that trigger when they are absolutely 100% necessary.
Now this is a powerful and really crucial point from the guidelines. When a patient becomes a clear danger, the whole dynamic of consent just shifts. Their right to refuse care gets superseded by the need to protect them and everyone around them. This is a critical legal and ethical line in the sand.
All right, so what happens when de-escalation fails and the danger is right there in your face? Well, that brings us to physical restraint. But make no mistake about it, this is not a first step. It is a last resort, and it is something that has to be executed perfectly.
The process here is precise, and it's methodical. You position the patient sitting up. That's to protect their airway. You secure all four limbs to prevent injury. But check out step 3 because it's critical. Every restraint has to be quick release in case there's an emergency. And if handcuffs are used, that key stays right there with the patient. You see? Every step is designed for both control and safety.
Okay, this is so important. You restrain to the frame, not the rails, to prevent injury if the rails get lowered. But the biggest don't here, the one you absolutely cannot mess up, is placing a patient face down. This, along with anything that restricts chest movement, can lead to something called positional asphyxia, and that can be fatal. The patient must be able to breathe freely, no exceptions.
Sometimes, even physical restraint isn't enough, or the struggle itself becomes dangerous. This leads us to chemical restraint. And if physical restraint is a last resort, this requires an even higher level of caution.
The core trade-off here is pretty simple. These medications calm the patient down, but they can also suppress their breathing. This is never a fire-and-forget solution. The second you administer that sedation, you are now committed to constant, vigilant monitoring of their airway and their respiratory status.
And here is another absolute line in the sand. The decision to sedate a patient is a medical one, based on your clinical judgment. It cannot be made at the request of law enforcement alone. You, the provider, are responsible for the patient and the medication. Period.
So why would you even take this risk? Well, because the alternative can be even more dangerous. Severe agitation can cause what's called acidemia, a dangerous buildup of acid in the blood, which can lead directly to sudden cardiac arrest. So in these cases, sedation isn't just for control, it's actually a life-saving intervention.
So, the patient is restrained, physically, chemically, or both. The struggle is over, but the danger is not. In fact, one of the most critical phases of care is just beginning.
As you can see from this timeline, the care actually intensifies after restraint. Immediately, the patient goes on a cardiac monitor. You're getting vitals. Then, every 5 minutes, you're reassessing vitals, airway, and their overall status. And on top of that, every 15 minutes, you're assessing their neurovascular status. That means checking the circulation, sensation, and movement in their hands and feet to make sure the restraints aren't causing harm. This is constant, active monitoring.
So, let's go back to that moment. The patient is secure, everyone can finally take a breath. Is the crisis over? No. The fight for control might be, but the fight for their life has just entered its most critical phase. Your vigilance is what stands between a safe outcome and a tragedy.